Thank you for the opportunity of you've given us, and I hope you find the session worthwhile and interesting. But also, we're also joined with, it'd be remiss of me to forget that we've also got another colleague along with us. Bev Havard is with us. Although not presenting, Bev will listen in and hopefully answer any questions that sort of come her way. Bev was a ward system manager from Reeves Talbot Hospital and now works with the HCW. So we're also joined with Bev. So today's presentation, I will start. I'll hand over to Lesley and then Keith will conclude. What we present is the Welsh Nursing Care Record, which is WNCR. And it's a system that we have implemented across the whole of Wales now and is utilised in hospitals, secondary care settings, across all of Wales. So it's now in 41 hospitals across the country. And I'll go through what the system is briefly and describe to you the lessons we've learned in terms of implementing that over the last 2 years. And you'll notice the key theme through it, as we titled this, is people. People is the key thing in terms of the key lessons we've learned as we implemented the system. So if you could go to the next slide, please, Keith. Okay, in terms of context, I'll talk through the left-hand side of the slide itself. You can see within that circular picture there's some very old filing cabinets there. And also next to the filing cabinets, you can see an iPad, which is enclosed in a protected case. This picture is taken in Betsy Cadwallader, it's one of the hospitals up there, but rather represents what the system actually is and what it provides. But before the system was put in place, there was numerous paper assessments of patient that was admitted to the secondary care assessment setting. So an individual that was in a ward bed would be subject to numerous paper assessments depending on their needs. So before the application and the system was actually implemented, you could imagine the filing cabinets were full of paper assessments to enable a nurse to manage an individual in a ward perspective. What we've done over the last 2 years is to remove that paper and actually digitize it and put it on a range of devices, and the device shown in the picture is an iPad, which obviously is a computerized, digitized system which replaces the paper that was previously used across Wales. So yeah, rather than using those documents, it's used on a computer. As I say, you can see from the picture, it is across all Wales now. All local health boards and Lindra trusts have implemented the system. We now have 260 wards using it, which represents 72% of all wards across Wales. We're aiming to get to 90 to 100% by the end of this financial year, and the financial year end for us is March 2024. I believe we'll probably meet that before then, but overall that's where we're looking to get at the end of this year to complete it. If you go to the next slide, please, Keith, it will show some statistics of the system. I'll go down the left, top to bottom, and then the right, because it sort of explains the picture slightly. Some of this I've mentioned, it's across Wales, 72% already implemented. The number of users across Wales, which is increasing obviously each month. But last month there were 17,000 users across Wales, and we've had 15,000 distinct users since go live. We have temporary accounts obviously to support the system, and since go live 44,000 temporary accounts have been used in the system. In terms of the number of patients going through, we've had over 120,000 patients. They've been digitally assessed, so they've gone through hospitals, actually been in and actually been discharged in a total of 120,000. And how much is being used? We've got two main areas of the system. One really we call risk assessments, and the other one below that we call nurses' notes. And respectively, we've had 4.2 million risk assessments completed and 4.4 million notes written in the system. The breakdown of the risk assessments, the 4.2 million, is on the right-hand side, and we now have 9 risk assessments available on the application. So there's pain assessments, which is the most commonly used risk assessment, and there's a regularly used assessment for any patient that's in the hospital. Then there's skin pressure, also risk assessment, continence, falls, patient handling, nutritional, bowel, skin, and mouth care. So all those large numbers, if you added them all up, I hope they do add up to 4.2 million, but that's where the breakdown of those risk assessments come from. We also have the ability to share these assessments across boundaries, and so if someone was in Florida and someone in Paris wanted to read an assessment, they have the ability to do that through the National Depository and the Welsh Clinical Portal. And last month it was 17% of the overall figure that was placed in the National Depository was shared across boundaries. So it has the ability to do that as well. Okay, the next slide, that's a little bit of context. I think we go to the next slide. It gives you a little, we'll go into the detail really of what we learned 24 months in now we are in terms of implementing the system. And we engaged and initiated a significant piece of work in terms of what we learned over those months and how we documented it was basically really unique to this presentation. And I'll talk through this slide. And the detail of this slide was expanded on by Lesley. Really. So around about the summertime last year, Lesley, myself, and the project support manager Adam started to look at what we've actually learned from the last 24 months. And we split this into 2 key areas, which was pre and during implementation, which is point 1, and the second point is post-implementation. So point 1, pre and during. That was the pre part is actually before we actually commenced at award level, and we also overlapped that into sort of during, so the start and the duration of what was award level implementation. And the second part we divided into post implementation, and that was basically once we'd completed award level implementation, we reviewed how that implementation had gone and captured lessons during that period. What we found in both those phases, both phase 1 and 2, what we found there was 3 key themes. Everything fell into 3 key themes, and they kind of go up into sort of the Venn diagram presented there. But the first one is environment and devices, the second one is quality, and the third one is people. And obviously, as the diagram explains, they all overlap and relate to each other, but the core one is the people one that embraces everything we learned. So they were the 3 themes we learned, and if we go to the next slide, it expands on that core model and evolves in terms of some of the specifics we learned during our overall implementation. So Lesley will take us through that.
Okay, thank you, James. As James has already explained, I think because whilst we started to collecting lessons learned last summer, it really started from the very beginning. We were very keen to learn all the way along and all the way along the journey. And I'm not taking anything from our IT colleagues because the app was so intuitive and not complex. It meant that as a team of clinical informaticians, we could concentrate on the people. So the people became all important. This was going to sink or swim really on the people we were able to bring with us. So the lessons learned were captured right from the beginning. And I joke about this and say it was everything from having a room near where you're going to roll out and making sure you had chocolate biscuits, coffee and stuff in there, and attracted everybody to come and see the activity. This wasn't a hidden rollout. This was very much come, have a look, see what we're doing, pop in, even if you're just curious. So we started with the people, and I'm starting at the top of this slide. The engagement was key, and the people we initially thought we needed to go out for was the ward staff. But actually, very quickly, we learned that the senior leaders and managers who might not engage with this system every day were absolutely pivotal. So we started engaging with them before we even got into the environment of care. And that really helped. And we did tours as well. We really varied our training, one-to-one group sessions, small bite-sized videos of every aspect of the app. These were absolutely pivotal. You know, everything down from how to make a temporary user access to how to access the first assessment was done in 2-minute videos. So people could, at their leisure, look at these. We also encourage access to people outside of nursing, so our allied health professional colleagues. The social worker access has been a little bit of a journey, and I'll talk about that as we go on, but we're currently at the doctors and surgeon type access to it. It was really important for us to listen to staff whilst we were explaining the app so that we could hear their worries. Because as you all know, wherever we work at the moment, recruitment is a real issue, recruitment and retention. And we didn't want anybody to take this as an opportunity to say, do you know what, we're going digital. I think I want to leave. You know, I've retired and returned, and I think we didn't want that. We wanted people to see that it was an app for all and take that approach all the way. Certainly now, as we are en masse engaging with our healthcare support worker staff to use the app as well. This is the largest workforce in the NHS, and I can't emphasize to you how much of a culture change this is. They were completely on paper, and now we're saying, put this straight into a digital mechanism. So it has been a complete culture change. The quality sort of grew in the background. We all sort of knew that it was there and it was going to be the mainstay of this piece of work if it was going to sustain and survive. But it ran all the way through. So the communication from the national team out and vice versa was really important. So we had people in every organisation, in all of the 8, just as James said. And we kept going with newsletters, evaluation. We had face-to-face meetings, which were really regular, and we visited areas as well. And we measured progress. What we didn't want was this, because we've had many digital systems and you hear your clinical staff saying things like it was like feeding the beast. We didn't want that culture. So in each of our areas, we've fine-tuned how we give this information back to people, and we've asked them how they want to receive it, because you can really overwhelm people with information as well, which is something that we didn't want to do. So as a team, we were desperate to celebrate some of our successes, and some of that, as we were doing it through COVID, needed to be celebrated. Unfortunately, through Teams, we'd have like 4:30 Teams catch-up meetings through COVID, just to see how they'd managed to roll out. And you'd think it was the same system being rolled out in multiple hospitals across Wales. They all hit different hurdles. And I think that was really important to note. Access was absolutely key. You know, as we mentioned, taking the people with us, you had to train to the system. So nurses didn't routinely use. I suppose here I need to talk for a little minute about interoperability. And what I mean by that for us was nurses didn't routinely use a lot of other systems. So with this system, we suddenly had to teach on things like the PAS underlying system, the use of the clinical portal where we normally put results. These haven't been routinely used. So that meant that there was a wider need to look at training. And it was really good to show the compliance with the data and give that feedback back to areas so that they could start to learn from it. There it notes that pilots were really important. What was important about them wasn't so much running the pilot, it was much more about the pause afterwards, because then you could start to learn if people were having little workarounds. They're things that you can't often test for in a UAT because they come with the longevity of using an app. So that pause proved to be really important. Pause before we moved on, and we often paused after doing a chunk of wards or even a hospital. So if you'd roll out in a hospital, you'd pause just for 2 or 3 weeks just to see how they'd be managing with it. And that became quite pivotal as well. We do currently have to manage the split between digital and paper, and people do favour digital now. So that means that the paper is being less utilised. That's something we need to keep on our radar, because we are going down a journey to become fully digital. We are not fully all in. If I had to put a percentage on it, it would be around 50 to 60% digital nursing notes. So, you know, you can do the maths, the remainder remains on paper, and that's something we're managing that risk. We always had to have one eye on business as usual. That became important from the beginning because we didn't want to live in project. So taking our local ICT colleagues with us throughout this has meant that we've actually managed to grow an amazing local team in all of these areas, where really speaking in different departments, they may not have spoken as much. Now it definitely feels like we are one team. I'm just going to touch on a little bit about outside individuals having access, outside the NHS, I mean our local authority individuals. So social worker access in one fell swoop with WNCR, we took the ability of social workers to look at the notes away at a time when social workers weren't coming to the ward because of COVID. So that's probably been our longest journey in how we've now managed to get them access to the app, and they can manage on their own devices to see patient care. And that whole idea was to try and fast track patients out of hospital. I think it's early days, but certainly where we've done this, it's proven to be invaluable. So moving down to the environment and the devices then, this has been absolutely key. So I've talked a little bit about involvement and a little bit about access. I think the thing that all of us hadn't really anticipated was the space that was required for these devices in clinical settings is often a little bit on the aged side. And then you've got these brand spangly new devices coming into the environments, and that the clinicians didn't necessarily feel the need to own them. So if they would break, they wouldn't see it as their responsibility to report it. So there was lots of thinking we had to do around exactly that, and ensure that we gave the devices to the clinicians and said, if they break, report them quickly because your replacement will come sooner, as opposed to them thinking that ICT were going to pop around and sort this out for them. And it was clear as well, I think we all thought, oh, we'll hit on one device and we'll all have the same device, but people are different. So the split of having laptops, tablets, and different devices has proved invaluable for eyesight alterations that people have, for the ease of being able to take it to the bed, and for other apps that are coming down the line, like we are all grappling with e-prescribing now. Having one device that can do all this will serve people well in the future. Keith, can you go to the next slide? Thank you. Okay, so just in a little bit of a summary then, these are some of the key messages that we took away from doing the project. Involve the people and we involved patients, staff, and the wider team, and that was absolutely imperative. We shared everything across Wales. We blew the competition out of the water. You know, people used to feel quite competitive about wanting to be first, but in reality, it is much better to share. We collected info all the way through, from the opening of the project all the way through, and kept just logging it, chucking it into an Excel spreadsheet before it was drawn in to a nice little report. And expect a culture change, because staff are definitely working differently and now joyously asking for more and more digital, because we've sort of allayed their fears, because we've tried to take everybody with us. It has really cemented the IT and clinical workforce out there. And if we move to the next slide, it is about taking the workforce with us. I can't emphasize enough, this is the largest workforce within the NHS, qualified and unqualified staff alike, and they're all utilising one system. I think what amazed me in walking the wards in uniform is how very proud all of our staff felt. I wouldn't have said a digital system could do that, but they are incredibly proud because they feel like they own it, which is absolutely beautiful to see. So the last slide for us, and I think this is where we all are, is, you know, when a journey has been worth it, when the answer to the question, would you do it all again, is yes, but better, as we have learned so many lessons. And that's unbelievably true for this system. Thank you very much. I'm going to hand you over to Keith to do our little roundup.
So the Welsh Nursing Care Record service is one of a number of programs, and as we all know, digital healthcare is constantly evolving. And whilst the pace of change is rapidly increasing, there still needs to be that stopgap to just pause, take stock, look at what we've delivered, look at all the successes, all the failures, what went well, what didn't go so well. For WNCR in particular, there are always a number of people involved. And so gaining their feedback of how the service and how the product's being used and how it was delivered has always been a key to the success of the programme. There's also been a number of external parties that have also been interested in this, and there have been a number of other reviews and reports that have also been undertaken. Overall, though, it's been very important to take all of the feedback routes, review them, find out what worked well, and then identify what lessons we can take so that we can implement them into the delivery of other products and other programmes. Within NHS Wales, this is typically done through improvement groups or learning groups, and there are a number of meetings that always go on which run through all of these. And part of the success of these groups is that level of engagement. And Lesley and James have both mentioned engagement all the way through this, and we can't reiterate that enough. That you need to be talking to your clinicians, you need to be talking to the users, you need to be talking to IT managers. You also need to be talking to the people that you probably don't think you need to talk to. So people like your service managers, your product managers, your information governance people, they will always have some thoughts and feedback on how to improve. But also what might work for one area might not work for the same area in another health board, in another organisation. But again, it's that continual engagement, and that should still be key to sharing those lessons. Final thought, it can't be underestimated how much having a people-centered approach has led to the success of this programme. And that's been down to a huge collaborative effort across NHS Wales and also with the Welsh Government and other parties. Whilst there have been highs and lows along the way, having that clear goal meant that everyone understands what they're working towards, and so they can all share in the successful delivery of the product. Just want to say thank you very much for this, and it has been a journey for Lesley and for James and for everybody else that's been involved.